Good evening. I'm Len Brazis, and I am the Executive Director of the Association of Healthcare Journalists. And on behalf of the Board of Directors and the staff of AHCJ, I want to welcome you to Health Journalism 2013. It's been 15 years since a mere handful of health reporters sat down together with the thought that helping each other with ideas and resources and learning could lead to better stories for all of them. That handful has since grown to nearly 1,500 journalists, representing this entire country and 25 other nations. That's 1,500 members in 15 years. And the original intent remains the same. Journalists helping journalists do a better job in covering healthcare. We're thrilled this year to be in Boston, the home to so many great healthcare experts and resources and healthcare experiments. We want to thank our sponsors, including our conference hosts, Boston University, Boston Children's Hospital, and Harvard Medical School and Harvard School of Public Health, and our endowing sponsors, the Robert Wood Johnson Foundation and the Helmsley Charitable Trust. Please take a moment to check out the rest of our impressive list of sponsors in the program who help make a conference of this size and scope viable. We do have record attendance this year, and we're hoping to be able to fit you all into all the rooms. And visit our exhibit hall and meet the sponsors and the exhibitors and see what sorts of resources they have to offer. We were able to put together the conference this year with the help of a local planning committee, journalists working within an hour or two of this building, who were willing to brainstorm with us and review many of the great speakers you'll meet this weekend. A couple of quick housekeeping items. Please make a note to yourselves to attend our Saturday morning news briefing, where we will debut our new news app, hospitalinspections.org. And after our kickoff sessions this evening, we will have our opening night reception just upstairs in the City View Ballroom. Now I want to thank the leader of the local planning committee, the Boston Globe's health and science editor, Gideon Gill, who will introduce our first guest for this evening.
Thank you. Most of you have no doubt read and heard a lot about the Massachusetts health insurance law passed in 2006. It requires most adults to have insurance coverage. About 98% of residents now do. And it became the template for the Affordable Care Act. You probably heard it called Romney Care during last year's campaign, much to its namesake's chagrin. Our former governor helped craft the bill and signed it into law. Let's see what works here. So there he is, signing it into law. What you may not know is that Governor Romney's successor has largely overseen implementation of the law. And Governor Deval, our speaker tonight, has also taken steps to slow the perpetual growth in health costs. Among them is another Massachusetts first, putting the state's healthcare industry on a budget by setting a goal for health spending to rise no faster than the rate of growth of the overall state economy. The governor is so proud of that legislation that his staff asked me to show the picture of him signing the bill last August. They also have been quietly testing a new name for the Massachusetts healthcare law in focus groups, a name they've given us permission to unveil today. For those of you who just tweeted that, I'm kidding. Seriously, Governor Patrick grew up on the south side of Chicago, but had the good fortune to win a scholarship to a prestigious private high school in Massachusetts through a Boston-based charity called A Better Chance. That led, after a few years, to admission to Harvard College. He was the first in his family to go to college, and then Harvard Law School. After working as a lawyer and executive for companies like Texaco and Coca-Cola, he was appointed Assistant Attorney General for Civil Rights by President Clinton, the nation's top civil rights post. He then returned to Massachusetts and was elected governor in 2006 and is now serving his second term. It is my pleasure to introduce Governor Deval Patrick.
Thank you very much, Gideon, for the warm and funny welcome. He was about to, when I actually saw the first picture go up, I thought, how do I smoothly ask him to remove it while I speak? I saw the second picture, and it seemed a little sweet. No, actually, that you can leave. Thank you, Len. I'm glad to be with you all, and I welcome everyone to Massachusetts. We're delighted you're here. I'm thrilled with the record attendance. I'm a little concerned about the time of day when I was asked to come by, because I have a sense I'm between you and your cocktail. So I'm going to keep my remarks brief, and then I understand we'll take a few questions or comments or advice. And if you are like journalists locally, it'll be mostly in the form of comments and advice. You are in the right place at the right time for a discussion on health care reform. Throughout my time in office, health care has been a central issue that we've been working on, as you heard Gideon describe it, how to expand access, how to improve quality, how to control costs. I don't think this is surprising. In one form or another, health care affects everything: government, business, and household budgets, people's ability to get a job, a child's readiness to learn. Given the significance of health care to so many aspects of our lives, I think we have been right to pay attention to these issues. And 6 years in, let me give you my perspective on where we are and where we're going. By any measure, I think, health care reform in Massachusetts has been a success. Today, we have virtually universal coverage, as you heard Gideon describe. I don't think any other state in America can touch our levels of insured citizens now, residents today. More businesses offer health care to their employees today than before health care reform took effect. That was a big concern at the time, so-called crowd out. In fact, it's 76% of Massachusetts businesses who today insure their employees, far more than before 2006, and well above the national average. Over 90% of our residents have a primary care physician, and 4 out of 5 have seen their primary care physician in the last 12 months. Preventive care is up. More people are receiving cancer screenings, more women are getting prenatal care, and visits to emergency rooms have decreased. 150,000 people have stopped smoking because we expanded coverage for smoking cessation programs, and we are healthier because of it. Women, minorities, and low-income people have experienced the biggest health improvements, but it's been true really across the board. For example, among Hispanic males, a notably underinsured population in Massachusetts before health care reform, the detection of testicular cancer has more than doubled, and the majority of cases are now detected at an early treatable stage. With increased access to screenings, we've seen a 36% decrease in cervical cancer in women. By the way, expanding coverage added only about 1% more of state spending to our budget. Those are the stats. Even better are the stories. I have met young women and men from all across the Commonwealth who've had their cancers detected and treated, their lives saved, really, because for the first time in their lives, they've had access to affordable care. I met a young entrepreneur who told me about moving his business here from Florida because he wanted to be in a place with a young family where he could be assured of health care during the early lean years of that business. Policy, in my view, matters only where it touches people. It's abstractly interesting in the abstract, but it matters when it touches people. And because healthcare reform in Massachusetts touches people in such positive ways, it's been a great success. And I think that's why, by the way, it continues to poll very positively among our residents. I forget what the latest numbers are. You probably remember, Gideon. But it's remarkable. During the campaign, during the president's campaign for re-election, I was struck by how the Affordable Care Act polled in Massachusetts about 50-50. Healthcare reform in Massachusetts polls in the 70 and 80% approval. They're the same thing. The same thing. I think as important as the policy for us has been the values that underlie healthcare reform here, and the means by which we have accomplished these results are equally so. For us, health is a public good, and we believe everyone deserves access to affordable quality care. We see access as an expression of the kind of commonwealth we want to live in and the kind of community that we are. That value was meaningful enough in 2006 to compel a Republican governor, a Democratic United States senator, a Democratic legislature to work together with organized labor, with business groups, with medical professionals and patient advocates to invent healthcare reform. And here's the critical part. And then they stuck together to implement it. They stuck together to implement it. And I think that's especially important because they realized that this was too big an undertaking to simply pass legislation and then expect that things would work on automatic pilot. That approach has been just as important in crafting and now implementing the next big chapter in healthcare reform in Massachusetts. The second picture you saw there, not exactly, but represented there, and that's cost containment. Last August, I signed legislation that takes this next big step, and that bill makes the link many have long recognized between better health and lower costs. So we are moving away now from a sick care system to a true health care system, away from fee-for-service care to paying for health outcomes and quality of care. Through a series of tools ranging from enabling new care delivery models to capping the rate of overall cost growth to medical malpractice reform, our new law will result in nearly $200 billion in health care cost savings over the next 15 years. I am confident that just as we showed the nation how to deliver universal care, Massachusetts will be the place that cracks the code on cost containment, and I'm really excited about that. We're working now on implementing the Affordable Care Act. It will take time and care and thoughtfulness, and there will undoubtedly be hiccups and challenges along the way. But we will come back to our core principles, that health is a public good, and that all Americans deserve access to quality, affordable care. And we remember that the success of the ACA depends on the same formula that has made Massachusetts health reform successful. That is the important, and that is that we do this important work together. I'm delighted you're here. I welcome you again to Massachusetts, and I look forward to your questions. Thank you. You want me to field them, or you want?
So if you have questions, please come up to the microphones in either aisle. Do we have any questions? I'll start off with one. Okay. So, Governor, do you have an idea of, or what is your thoughts on why healthcare reform in Massachusetts is so much more popular, state health reform, than the ACA here in Massachusetts?
Well, I think, for one thing, we sold it. We marketed it. You don't have to keep that up there. Just realized now I'm looking down at the screen. It's kind of if we do rename it, it's Patrick Care. Okay, it's not Deval Care. Okay. Just want to be clear about that. Remember, a broad coalition stuck now, isn't it? It would be. This broad coalition created healthcare reform, and they were very invested in it. So it was not policymakers alone, it was not business leaders alone, it wasn't the healthcare industry alone, it wasn't labor alone, it was all these folks. And by the way, the fabulous part of this, I think, because this was all happening while I was running, is that collectively this group said, that there was a third choice rather than the usual two. Because the usual two were a perfect solution or no solution at all. And so he said, let's try something. Let's just try it. And if it doesn't work, we'll refine it as we go along. So I think that spirit was important, and because the coalition was so broad, they were very invested in it. Now, the marketing part of it took some wonderful forms. There is a group that we refer to here as the Invincibles. You know what I'm talking about, Gideon. These are the people I used to think I was. 20-something men, mainly, in great health, who didn't need and didn't think they ever would need health care reform. And yet, the whole insurance model is you got to have everybody in the pool in order to bring costs down for everybody, system-wide. And so there was a lot of work done about how to reach them. And what did we do? What did the coalition do? They did advertisements during Red Sox games and Patriot games up on the Jumbotron. And they got sports folks to talk about coming into the affordable. So people made it a thing, and I think that really made a difference. Sorry.
Yeah, you said that.
Yeah, please identify yourself.
Okay, I'm Carl Stark from the Philadelphia Inquirer, and I wonder what's the copay for Deval care? No, it's just a joke. I was wondering if you think you said that after you passed the bill, you said that you stuck together.
Yeah.
The governor and the Senate and the legislature. Do you feel like Obama really made a mistake in not fighting for ACA harder? That it could actually be a situation, that the bill is 50-50 in Massachusetts, while the model for the bill is 70-30? Or alternatively, do you understand what their thinking was? I mean, why they didn't defend it more?
Well, I don't. That polling I referred to is 3 years old or something like that. I don't know actually how the ACA polls here now, but I do think that the administration, which I enthusiastically support, was slow to defend health care reform, and not just the impact on people, which is profound and positive. I mean, ask anybody who's got a pre-existing condition or who has been thrown off their health care because they got sick. So it wasn't there when they ask anybody in those situations the value of it, and they say, yeah, I get it. I think it was I'm a Democrat. We constantly get outplayed by the right on Reddit. We do. I mean, it happens all the time. We get so into the policy details that we forget to talk about the values that underlie those policy choices, and the values are powerful. So I do think that the administration was slow to do this. I think it was a great boost at just the right time for the Supreme Court to have issued the decision they did, and I think, frankly, we've been building since then as more and more of the more recalcitrant or resistant Republican governors have been coming into the Medicaid expansion, so bit by bit.
Thank you.
Yeah, thank you, Carl.
Question up here?
Oh, she was first.
Oh, okay, thank you.
My name's Sarah.
You guys must be from out of town, because I have the journalists here just don't act like that.
My name's Sarah Okeson. I'm a reporter from Springfield, Missouri.
Sarah.
Which is somewhat out of town.
Uh-huh.
And I'm interested in why Massachusetts has supported medical respite care and why the state Medicaid program pays for that.
I don't know. I mean, respite care meaning
Meaning like respite care for people who've been discharged from hospitals but are still too frail to go home, people who are homeless.
So some of that is new and is related to the cost containment models that we're trying to encourage. And let me back into the answer. There was a pilot done, I think, at MGH, at Mass General Hospital, with CMS a couple years ago, when CMS was saying you got to get the readmission rates down, because readmissions were one of the drivers of their increases in costs, and I think that's true everywhere. And MGH did some analysis and said, well, you know what, the stuff that it takes to get those readmission rates down, you don't reimburse. And so how can we do something where there's an upside in this both for CMS and for MGH? And one of the things, for example, they were getting at was people doing their physical therapy and taking their meds and so forth afterwards and having that monitored. So CMS worked with them, with MGH, on a plan where they would split the savings in reduced readmissions. And MGH would use that money to pay the social workers and others who would go out and make sure that folks were doing what they needed, following the instructions they were given, Sarah, when they left, to make sure that they would get better and not have to come into the hospital. And there were such dramatic savings in such a short period of time, it really built on this case that whole person care, which is actually better quality care, also reduces costs. So my guess is that the respite is built in for that, for precisely that reason. There are models like that being tried really all over the Commonwealth right now.
Thank you.
Thank you.
Ready to go now?
Yes. I'm Jerry Shaftel-Constant from KTTV Los Angeles.
Welcome.
Thank you. I just wonder what the impact of mass care has been on people with private insurance. Is it harder to see to get an appointment with a primary care doctor, and what has the impact been?
We had a lot of we had a lot of concerns about capacity going in. By the way, I didn't fully appreciate this until I was trying to learn about it during the because all this was unfolding when I was campaigning the first time. For governor, and was this fabulous primary care physician and teacher who helped me understand that if we really got this right, we might not actually have enough primary care physicians, and that one of the biggest constraints around private care physicians, not just here but elsewhere, is how the cost of medical education and the debt that goes with it makes it hard for doctors to choose primary care rather than a higher compensated specialty. We did a couple things before the global economic collapse to take the edge off that in terms of capacity building and around loan forgiveness. And we did that together with a couple of companies who were willing to kick in. Got some big upside, but we had to cut it when the budget was really under stress. Big help for us has been the community health centers, which are just an incredibly efficient and broad network. And I will tell you, you heard the stat I read about over 90% of our residents having a primary care physician and actually being able to see their private care physician 4 out of 5 in the last 12 months. Even I was surprised by that. You know, I get to see my private care physician when I want, but I think it's because I'm governor. I'm not kidding. I mean, I think I can. I think that's why. But I am surprised, and it's enough to make me want to run for another term. But I think it is heartening to see that to see this stat. I think we do have some differences by region, though, and out in western Massachusetts, which is more rural. We have greater challenges in terms of capacity and access to primary care physicians than we do in the greater Boston area. So we still have some work to do here. Thank you.
Time for just 2 more questions. So right over here and here.
Governor, I'm Katie Butler. I'm an independent journalist in San Francisco.
Hi, Kate.
Hi. I have a political question about cost containment. Mm-hmm. People say that about a third of what our spending is either inappropriate or overtreatment inappropriate care or overtreatment in one way or another. Mm-hmm. So there are huge issues of waste, and as we know, one man's waste is another man's stock dividend or second house.
Well,
Yeah.
or another patient's second opinion. I mean, it's
Yeah,
Yeah.
yeah. So as you move into cost containment, it seems that the political issues around getting some types of costs cut may be much more difficult than putting that original coalition together.
right, right.
So, I mean, for example, you know, device manufacturers have a very, very high, stable profit every year, and a great deal of pressure can be put in Washington through lobbying to structure how Medicare reimburses, for example, which then affects treatment decisions of the kind that you're straightening out.
Yeah.
So is it easier on a state level to balance those competing interests and balance out perhaps the overpower of lobbying that lobbying has in Washington on how medical legislation is shaped?
I don't know the answer to that, Kate. I do think that it's not going to be solved at either level of government alone. There's some observations, I think, that it informed our experience. One, I want to acknowledge that getting to the cost containment legislation was hard. And when the folks who were involved in it, in most cases, had been involved in the first round of the access expansion, and they had put off cost containment on purpose then because it was hard.
Yeah.
I can't imagine that the lobbies in Washington are any more powerful than the healthcare industry is right here in Massachusetts. This is a central part of our economy.
Yeah, yeah.
And you get a lot of what people describe as the golden egg concern. Let's not kill the goose that lays the golden egg, which, you know, sounds a little, at some level, like the argument people may have made in another town in the Commonwealth that was the worldwide center of buggy whips when you know, cars were coming along. Let's not have any cars because we might threaten that underlying economic. The economy is dynamic, right? And it's always dynamic. It's dynamic within the healthcare sector. And the more we talk that through, the more comfortable, I wouldn't say resolved, but the more comfortable people were with the parameters of the bill we ultimately got. So I do think it helps to have some government involvement, but it's not going to be done by government alone at either the state or the federal level. It's going to take a collaboration. I will say this too, that the focus on outcomes and agreeing on what those quality measures are is really critical from our perspective. And then turning back to the healthcare industry and saying, okay, here are the parameters, you figure it out. Because people do not buy healthcare the way they buy soap. It's not the same market. Doesn't mean it isn't important to use the market and market principles, but it's not the same thing. And so that's a balance I think we're trying to strike, and I think you see that in our bill. And you know, time will tell.
Yeah.
I'm sorry, we just have time for one more question, and you were first.
Hi, I'm Margot Sanger-Katz. I'm a writer at National Journal in Washington.
Hey.
And you mentioned that you had a lot of support from the business community across the political spectrum as you were implementing the health reform law, and also you had a really targeted group of people that were uninsured that you needed to reach. You also had a really small percentage of your population that didn't have insurance, and so
Going in,
yeah. So I just was curious, as we're getting into the implementation of the Affordable Care Act around the country, and those conditions don't exist everywhere.
You're right.
How good a model do you think the success of your implementation is for other states, and how confident are you that we're going to be able to see the kind of success that you've had in places that don't have those same underlying conditions?
Yeah. So is it Margot or Margaret?
Margot.
Margot. There's one other thing we had going for us, is that we had a large uncompensated care pool. So we had committed as a state to pay for the health care of people who didn't have insurance through that mechanism. Now, frankly, we were spending a lot of that money in emergency rooms. But that was then used instead, in effect, to pay people's premiums. So we had that other advantage going in. I think many of those differences have been accounted for in the drafting of the bill and in the preparation of the ACA I'm talking about, and the preparation of the regulations as well. I mean, to the point where some of us who feel like we're out ahead don't always feel like we're getting the best deal. You know, if you are, I think it's 100% of new insured or new entrants into the expanded Medicaid who get reimbursed by the, there is 100% reimbursement for new Medicaid enrollees in most states, and who aren't at 98+% coverage. It's not that for us. It's like, wait a second, wait a minute. We did all this to show you what to do, and you're going to shortchange us. But yeah, they are going to shortchange us, and they did some of what they did really to make it more, to make it easier for states that had not gotten as far as we've gotten at the time of the ACA to come in, and then to back that off, feather that off over time. I think also the President and Secretary Sebelius have been very clear and have shown in a number of different ways the flexibility that they are willing to give to states to try their different methods and in some cases different timetables to get to the same result. So I'm hopeful.
I just wanted to ask one political question. Bruce Japson from Chicago.
Hey, Bruce.
But I write for Forbes. What's next for you? Are you going to run for something else? Are you going to go into
I'm
business?
sorry, my time is up. So, Bruce, since you're from my hometown, my original hometown.
Based originally from Iowa, where they're just waiting for people to come in 2 years.
Is that right?
Yeah.
Is that an endorsement? No, we don't have term limits here, but I have a term limit named Diane, and I promised her to. I mean, this is the first political office I've had, first race I've run. I've done it for 2 terms. We're going to run hard through the end, and then I'm going to go back into the private sector and try to find a job. And if there is another opportunity at another time where I feel I have a contribution to make that somebody isn't making, maybe then. But I don't have an elective office plan after this one.
All right. Thank you.
Thank you.
Thank you very much. Thank you very much.